p.m. Should we start? Am I audible to all of you?
Yes.
Yes. Good evening. Good evening, everyone. Good to have so many participants from the different corners of the world. Thanks for joining us today on the first webinar of South Asian Center of Excellence in Physiology, Education and Research, in collaboration with Pakistan Physiological Society, PPS, on the theme of innovative techniques in teaching and learning. I'm Professor Muneza Muhtashim from Nurse School of Health Sciences, Nurse University, Islamabad, and I welcome you all, and I'm excited to be your host for today's webinar. Today, our main objectives, our themes are key innovative teaching and learning strategies, understand their impact on student engagement and outcomes, identify practical approaches for integrated innovation into classroom and clinical teaching. We will also have time for a question-answer session at the end. So please feel free to submit your questions through the chat box. And a YouTube recording of this webinar will be provided to all the attendees at the end. We also hope that you will enjoy today's session. I would also like to request each participant to kindly introduce yourself before starting your presentation. So let's make this webinar a collaborative and enriching experience for everyone. So our first speaker is Dr. Udari. Should we start from you?
Yes.
So would you like to share your presentation?
Yeah, I want to share my presentation. Yes.
Okay, okay.
Can you all see my presentation?
Yes.
Okay. Good evening, everyone. Hope I'm audible to you.
Yes.
Yeah,
Yes.
okay. Yeah, so I'm Dr. Daria Godage, and I'm a consultant physician and a senior lecturer in physiology from Faculty of Medicine, University of Rubuna, Sri Lanka. Today I'll be sharing our experience in teaching basic sciences, particularly physiology, by integrating early clinical exposure. Traditionally, medical education separates preclinical and clinical phases, and students often learn theory without real patient contact. Lately, we've noticed poor lecture attendance and students express difficulty in concentrating and retaining context. In a recent study done in the university regarding perceptions of preclinical medical students on factors determining lecture attendance, we found that students showed more interest in clinical-based lectures like ECG and radioanatomy, and found small group discussions are more engaging, and they preferred interactive teachers who connect contents with clinical relevance. This links well with Malcolm Null's theory of andragogy, which emphasizes that adult learners engage more when learning is relevant to their needs and builds on their experiences. And looking back, Bloom's taxonomy highlighted higher order thinking and its importance, like applying, analyzing, as essential for deep learning. Later, we know Harrow and Cattell incorporated affective and psychomotor domains into learning. And this reminds us that medical education needs to go beyond memorization into transformation. So how can we teach basic science more effectively? So when we go through the literature, the most effective teaching comes with using active learning strategies and promoting vertical and horizontal integration. And integrating clinical context early. Incorporate visual and digital tools. And foster students' engagement and motivation are equally important. So when we think about this, early clinical exposure found to be particularly important. What is early clinical exposure? So the definition given is that it should be authentic human contact in a social or clinical context that enhances learning of health, illness and disease and the role of the health professional occurring in the first 1 or 2 preclinical years of undergraduate medical education. So in simple terms, it is a pre-clerkship, that is before students go officially for kind of clinical training in their 3rd year or 4th year. This is a pre-clerkship experience with authentic patient contacts. It should occur in clinical context, not like video based and not taking patient to the classroom. It just should occur in the clinical context itself. And they found that it enhances learning by making medical education more relevant, and it bridges the gap between theoretical knowledge and practical application. And certain advantages were found in this early clinical exposure, like as we discussed, enhancing the relevance of basic sciences and strengthening learning, and basic clinical skills training like cardiovascular system examination, respiratory system examination, and promoting career interest in primary care and specialty understanding, especially if we are taking the patients to the primary care or general practitioner setup, and just promote them and encourage them to show how they are working there and to get kind of a career related to that pathway. And encouraging active learning in preclinical settings and getting sensitive to patients' issues. And it can reduce the shock of practice during clerkship and aligning with patient and community perspectives and identifying professional responsibilities. So when we were creating a curriculum, we were trying to integrate a course in early clinical exposure to our traditional curriculum in the university, our main aim was to give more relevance and to demonstrate the relevance of phase 1 curriculum that we teach for the students in a way like anatomy, biochemistry, and physiology, and show that its relevance for patient care and introduce key concepts related to patient management to the students. So we wanted this to be a more structured program, but what that means is in the first term, We were teaching them Starling forces, IV fluids, how edema is formed. So at the same time, we were taking the students to the wards and showing them the patient with edema, how the IV fluid is given in the ward. And when they are learning about cardiovascular system, we took them to the hospital and we showed them a heart failure patient and asked them to listen to the basal crepitations, showing that it is pulmonary edema. And respiratory, allow them to listen to a wheeze and how it is formed, then we can talk about it later. So that type of real time kind of, a structured program was our plan. And when we went through the literature, we found which type of programs are more fruitful or showed more interest among students. And we found the structured programs with active participation provides greater impact than passive observation. That means like talking to the patient, examining the patients rather than just observing while in the ward. And the other thing is at the same time, supervision, reflection, feedback, all these things are crucial. And also just like allow them to peripherally participate and then gradually take them to the scenario and gradually take them to the third year clerkship experience. And this is a big step. I mean, this has not been practiced before. So we definitely had to do a SWOT analysis before starting the program. So there we found as strengths that we have qualified teachers who are motivated for change in teaching methods. So over the years, we were trying to vertically and horizontally integrate our curriculum. And so we made our like kind of case-based learning for the students, small group discussions with more case-based scenarios, and even in the exams we ask them more kind of clinical-based questions. So like gradual progression was there. And we have a dedicated medical education department in the university, and we have a large teaching hospital with multiple specialties and subspecialties, and it's like very close by. The student just have to cross the road to the other side. And students' willingness for the early clinical exposure was also important. And then we found that the limited number of teachers. So if I told you the 47th batch, the batch we were trying to implement this for the first time, we have 300 students in that batch. So we have 30 preclinical teachers, but fortunately we were helped by paraclinical staff and clinical staff as well. And I should tell you that we all our 30 academic staff are not MBBS graduates. Some of them are BSc graduates, but we have like over 70% MBBS graduates, and among them we have about 6 or 7 graduates who have done kind of, graduates means like lecturers who have done a postgraduate training in clinical teaching and clinical sector, that is like MD medicine or surgery, that type of thing. And obviously higher number of students and reluctance to involve in these type of activities. And we found as opportunities creating a learner-centered teaching culture and ability to experiment new educational technologies which are used in other countries, and students getting more opportunities to understand their future roles. And as threats, the resistance of academic members, like during the program, if they go away from the program, what is our next plan? And would there be resistance from the hospital and difficulty in finding relevant patients? Like, for example, when we are doing heart failure, ischemic heart disease, we can find patients. When we do endocrine, like, Addison's disease, Cushing syndrome, would we be able to find adequate number of patients? So before starting this program, we did a pilot project that is for the senior batch, that is for the 46th batch, and that was a PDSA or plan, do, study, act that should be done before any kind of this scale project. We should do such a small scale one. So we did one, and we found that we found satisfactory feedback from students and teachers, which paved the way for us to do this project in the coming months. And we created course intended learning outcomes, mainly based on kind of finding the relevance of the first year teaching for the students, and also other factors like improving the professionalism and ethical aspects as well. And hours wise, we started slow. Like first term we did 2 hours, we have now completed the second term, the 5 hours, and we are planning to do another 13 hours in the coming terms. We started with informing the dean, obtaining ward permission and group formation, and started doing kind of lectures related to this and ward visits. And not only that, we wanted to incorporate reflective writing for the students, because it can like reinforce what they learn from this. I will show you how we did that. So we taught them the reflective practice and its importance and how that cycle runs, and then we gave them a structure to do a reflective writing. We didn't ask them to do this every day. After the first 2 hours in the first term, and then we are planning to do another reflective writing again at the end of the course. And evaluation is important, and it's should not only at the reaction level, it should come in learning, behavior, and the results as well. Exposure from Mentimeter. So when I was doing the very first lecture for the students regarding the introduction to the clinical exposure, I asked their feelings about, or what are their thoughts about this program, and they were really excited. And I found like about 30% students have not visited a government hospital before, so it was kind of a total novel experience for them, and they were really happy to engage with the ward work. And this is the students' reflections after the first session, which were really rewarding. And they said, I became aware about the responsibilities that comes with profession and why this profession is devoted. And they said medicine is not just about acquiring knowledge, it is about applying that knowledge with compassion and dedication. And another student said, finally, I realized that the theoretical knowledge we are studying is meant to be applied in our clinical appointments. And then they said, relying only on theory made me feel a bit lazy towards my academic work, but applying those theories to real patients made me more eager to dive into my academic works with dedication. And it helped me to understand real life scenarios, and the students, I was feeling more connected to healthcare team and recognize that I'm also beginning to take on my identity as a future doctor, and they are going to improve, they are going to change their learning methods. And teachers' feedback were also mostly positive. They found the students enthusiastic, and they wanted to pay more attention in the future to improve the program, and they gave feedback like we could organize this more, and we could organize more lectures related to clinical teachings that we are going to do in the future. So we came across challenges like resistance to curriculum change, limited clinical faculty availability, and balancing preclinical workload with this clinical exposure program, and ensuring adequate supervision, which should be meaningful to the students, like otherwise there's no point of implementing this type of a program. And patients and finding patients and scheduling, all these things were challenging. So what would I say in summary? I would say summary isn't just a teaching strategy. It's a mindset shift. It creates connection, encourage reflection, and foster transformation. So thank you for allowing me to share this with you all at this webinar. And I'm hoping we will have more fruitful lectures and more lectures in the coming 1 or 2 hours. And thank you very much.
Thank you so much, Dr. Udari, for the wonderful presentation. In question answers, we will ask you in the end of the session. Now it's turn for Dr. Farhana Laila. She is going to present impact of integrated teaching after traditional didactic teaching on learning of clinically oriented physiology among phase 1 medical undergraduates. So Dr. Farhana is from Bangladesh. Dr. Farhana, would you like to share your presentation? Yeah. Hello? Hello, Professor Rita? Yes? Hello, yes.
Hello. Yes, we can hear you. Okay. Let me share my presentation first.
Dr. Farhana, Assalamu alaikum. Can you please switch to presentation mode?
I'm sorry.
On the top, there is a toolbox, and in that toolbox, there is this fourth icon, which looks like a slide and its base. So you have to click on that so that you can enlarge the screen. Presentation mode.
Okay, or at the bottom there is also a cup
Yeah, there
shape.
is also one at the bottom. So you can
also click there.
use definitely.
At the bottom of the slide, there is a cup shaped something. You can click on there.
Sure.
I can see anything like that. At the bottom of the slide on the right side. You can
Should I
see.
should I go to share option?
Okay.
Yes. First you have to go to share option and bring out your presentation.
Yes.
And now you have to enlarge it so that we can only see one slide at a time,
Yes.
the way you normally do it in your classroom. Yes, you have to click this.
Is it okay?
Perfect.
Yes.
Perfect. Go ahead.
It's perfect.
Hi everyone, Assalamu alaikum. Thank you for taking the time to join the session. I'm excited to share my presentation, my work which explores one of the most dynamic and widely discussed trend in medical education, integrated teaching. Was entitled as Impact of Integrated Teaching After Traditional Didactic Teaching on Learning of Clinically Oriented Physiology among Phase 1 Medical Undergraduates. The authors are me, Dr. Farhana Laila Lima, MD Physiology, Bangladesh Medical University, Professor Dr. Sultana Firdausi, and Professor Dr. Nahid Farhana Amin. So, what is integrated teaching? The Latin word integer is the source of the word integration, which represents the way to avoid the fragmented and irrelevant acquisition of isolated facts and transforming knowledge into useful tools. Traditionally, the medical student learned about different aspects of human body in strict isolation. Connection of basic science concept with clinical discipline is obligatory for developing clinical vision. Integrated teaching aims to do just that, help students think critically, linking knowledge across the discipline. There are different types of integration when two or more departments teaching concurrently merge their educational identity over a finite period of time is known as horizontal integration. And integration between different disciplines traditionally taught in different phases of curriculum is known as vertical integration. The very recent updated BMDC curriculum for MBBS 2021 has included integrated teaching in a small scale, which is about 30% of teaching. The sessions are on previously selected topics, which are carried out by different disciplines from different faiths. I'm sorry. In BMDC curriculum, phase 1 includes the basic subjects, phase 2 and 3 includes the paraclinical subjects, and phase 4 includes the clinical subjects. So we can clearly assume that the integrated teaching included in BMDC curriculum is a kind of vertical integration. And the approach of integrated teaching in physiology can help the student to understand the complex system of the body in an easier way. Before we fully appreciate the integrated teaching, it is important to know about the conventional method. We'll discuss about it in short, which is traditional didactic teaching. Traditionally, students learn the subjects in strict isolation, memorizing facts with little clinical relevance. As the students have a culture of listening, they become passive learners. In previous studies around the world, integrated teaching has been emphasized by the academicians, and it has been proved that integrated teaching helps in purposeful, relevant learning and better understanding of topic. As in learning process, assessment is an essential part since the learning objectives of the course can be judged by the assessment. So the recent revised curriculum needs evaluation as well. It is expected that it will help to realize the importance of applying integration at right time, at right place in curriculum, which may play a vital role in its operative success. These are the objectives. And this analytical type of study were conducted in Department of Physiology, Bangladesh Medical University, after taking the ethical clearance from Institutional Review Board, Bangladesh Medical University, where the study population were phase 1 medical students, and sampling technique was purposive sampling, and the sample size was 138, where 68 students were from first year and 70 students were from second year. And the study component was evaluation of phase 1 medical undergraduates' performance by a written examination after exposure to traditional didactic session and integrated session. The assessment tool was a single question paper on each sorted topic, which are prepared by using Bloom's taxonomy like recall, understanding, and clinical application level. And in total, 20 marks are allocated, where for that 10 single-based answer and 10 multiple-choice question of true-false type were constructed. Among them, for topic anemia and refractive error, 10 questions were basic concept type and 10 questions were clinical applicable type. And for topic coronary artery disease, 16 questions were basic concept type and 4 questions were clinical applicable type. And same question paper were used for both post-traditional and post-integrated evaluation, which was not previously known to the students. And the variables are test score and frequency percentage. For test score, the multiple true-false type and single-based answer type with their taxonomy level were evaluated, and for frequency percentage, the mentioned type of responses were evaluated. And data are analyzed by pair sample t-test and chi-square test, and data are expressed as mean plus minus standard deviation and frequency percentage. P-value is considered significant when it was less than or equal 0.05. How much impact does it really have on learning of clinically oriented physiology? Let's see the results. In the results section, all the red bar will represent the test score of post-traditional evaluation, and blue bar will represent the test score of post-integrated evaluation. And x-axis will represent the type of questions, and y-axis will represent the mean score. In this figure, we can see that the comparison of mean score obtained in multiple true-false and single-based answer type of question by all students. Here we can see that the mean score obtained by the students significantly increased after integrated session in answering all type of questions. And these figures are showing the comparison of mean score obtained in taxonomy level-based question on multiple true-false type for topic refractive error and coronary artery disease. Here we can see that the mean score has significantly increased after integrated session in answering recall and clinical applicable type of question. And this figure is showing the comparison of mean score in taxonomy level-based question for MTF in topic anemia, shows that the mean score has significantly increased in answering all level of question after integrated session. And these figures showing the comparison of mean score obtained in taxonomy level-based question of single-based answer after both sessions shows that for all the topic, that mean score has significantly increased after integrated session in answering all level of questions. And this figure is showing the comparison of frequency of different type of responses. Here we can see that the significant increase in percentage frequency and decrease in incorrect and unattempted trend suggests significant improvement in students' performance due to integrated teaching. So it has been concluded that integrated teaching is more effective approach after traditional didactic teaching for learning physiology to utilize its principle to understand and better management of clinical problem. These are the limitations. So the message we received from the outcome of the study is incorporating more integrated teaching topic into the traditional curriculum can enhance student clinical application skills. Thank you all.
Thank you so much, Dr. Farhana, for a wonderful presentation on integrated teaching, on highlighting its importance and its comparison from the traditional teaching. Now it's turn of Dr. Mohammad Rafiq Dar. He is going to present the modality-based tech learning. Sir, have you joined?
Let me call him. In the meantime,
Okay.
you can. In the meantime, you can invite the next speaker.
Okay. So the next presenter is Dr. Hania and Dr. Hera Moin. They are going to present the cooperative learning in medical education. Dr. Hera, can you share the slides, please? Join, Kiran, please. And her topic is the impact of Jigsaw technique for cooperative learning in undergraduate medical education.
Hello, it's my screen visible.
Hello, are you sharing?
Is my screen?
Yes, your screen is visible.
All right. Good evening. It's a pleasure to see you. I'm excited to be sharing this. Before we dive in about I'm Dr. Hayat and I've recently.
Please speak loud. You are not audible.
I'm Dr. Hania Sayed and I've recently completed my MBBS graduation and house job this year from Al Nafis Medical College.
She is muted.
University.
Please unmute yourself.
Further loud, please.
Okay. I've recently completed my
Her mic is off.
graduation. Is it audible?
Can you please sit close to the computer or wear headphones?
Is it? Hello?
Okay. Dr. Munazza, while Dr. Hania is having trouble with her mic and she will adjust her mic, Dr. Rafiq Dar has joined already. So let's give time to Dr. Hania to adjust her mic.
Yes, sure.
Thank you very much.
Okay, thank you.
Thank you. Thank you, Dr. Samina. Thank you, Dr. Manaza, for inviting me. Can you listen me, please?
Thank you, sir.
Yes,
Yes, you are
sir.
audible.
Yes, sir. Yes, sir.
So, if you can see the slides like this. So my name is Dr.
We can't hear him.
Sir, maybe
Voice
you
is
have
still
checked in by two devices, so we can hear some echo. If you can switch off one of the two devices, please.
I I'm on single device. I don't know.
Okay, now your sound is clear, sir. Please go ahead.
Okay. Thank you so much for the invite. Actually, my presentation is today on the teaching and training. Basically, this is not a true scientific thing, but I'm going to share you very important and emerging art on communication. And this is technically called as modality-based tech teaching. So even this communication is called as a kind of communication technology because it's really up to the mark way of teaching indeed. And this is called as neuro-linguistic programming. So basically, neuro-linguistic programming is a way of communication, and there are different techniques in this approach. And definitely, I will be going to share you only one technique, and this is called as the modality technique. And before I describe what is the modality, and let me introduce you what is basically NLP. And before NLP, let me share you what is teaching and training indeed. If I conclude teaching and training in just single word, I will say teaching and training is the communication. That means if you are unable to communicate, you are not teacher or even trainer. So communication here doesn't mean that you are going to speak and this is communication. No, speech and communication are different, two different things. And if I philosophically define what is communication in single word, this is response. So if I am teaching and I'm not getting any response, that means I'm not communicating. So communication means response. If you want to get a clear response from the students, I would really recommend you this very up-to-date kind of art of communication. This is called as neuro-linguistic programming. And you can manage your communication through this art. And let me define what is NLP or neuro-linguistic programming. As you can see, it's a combination of three important words: neuro, linguistic, and programming. In simple word, here, neuro mean your brain. So what brain actually do? Your brain is going to receive information through 5 different senses, like hearing, visuals, feelings, touch. So you can receive information through 5 basic senses. However, there are other senses as well, but the main senses, these are the 5 basic senses. You are getting information from outside and you are going to process in your brain. So what happens when you process all this information in the brain? You are going to create an answer within your brain. So first, when your answer is ready in the brain, now it's the language part that is going to transfer the internal answer to the audience. So what happens when I am going to transfer this internal answer to the audience? Might be my skills are so poor that I'm unable to deliver my talk to the audience, because audience got different personality, audience got different modalities, how they can understand. So the third thing comes here. This is the programming. So programming here means if you make yourself able to understand the audience, and then you are able to reprogram your communication style according to the audience, this ability is called as programming. So in simple way, NLP is if I am able to understand myself, then understand the audience. And if I can synchronize my style of teaching as the audience needs. So this skill is basically called as NLP skill. And for this skill, there are different techniques to understand yourself. There are different lot of techniques to understand the audience. There are a lot of different NLP uh, training and teaching pattern, how to choose a specific way of style for a specific person, for a specific student. So it is lot of techniques that are present in the NLP. Let me show you a few like techniques. Like there are metaphor technique, match and mirror technique, anchoring technique, metaphor, switch patterns, chunking, hypnotic approach, like to dislike technique. So these are the different basically techniques if you want to deliver a best answer to the students or any other audience. So there are different techniques you can see, but the most important and the basic technique is the modality. So if I explain you this only one technique, the modality, because I will be focusing only one technique due to lack of time, please alert me when my time is going to finish. I will try to wind up. So let me give you a concept. Every normal person is going to receive information. That means every student, if let me talk about the students, every normal student is going to receive the knowledge concept through four different approaches. Either he can visualize your concept on the board, on the blackboard, whiteboard, or in the presentation, and either he is or she is listening your concept. And there is third other important way to receive the information is through emotions. So especially when you are teaching, sometimes you got emotional, and when you got emotional, the next student is going to receive information in best way, because this specific student understands in a kinesthetic way, in an emotional way. And the fourth type of way we learn, we receive information is the auditory digital way. Auditory digital mean logical way. So there are four different ways we learn through. We learn through logics, we learn through visual, we learn through sounds, we learn through emotions. So these are the four different ways we receive or we conceptualize the things. But very important,
Excuse me, Professor Rafiq. Sorry for
Ji.
interruption. Some students are looking forward to see your slides as well while you are talking. So feel free to move your slides when you find it necessary. Thank you.
Yeah. Because you can see my slide. I think might be due to internet is slow. That's why maybe
Okay, they are
they
not
are unable
moving.
to see.
Yeah, actually, they are not moving.
Okay, let me. Now it's moving.
Thank you. No.
No, the slides are not moving.
Starts.
Okay, let me share again if I can, because I don't know.
Anyway, your talk is more interesting than a slide could be.
Right.
So we are paying attention.
You can continue. You can
Okay,
continue.
let me try, please, because the slides, because I'm talking on the communication, so your visual input is also important.
Yeah,
So,
this is just for the students whose modality of learning is visual, that they need the slides as
Dr.
well.
Samina know me, because this 20-30 minutes are not really good for me, because I just take a start, even 30-40 minutes I take, but obviously I can understand the importance of timing, and this is why I'm going. So hopefully now you can see, I guess.
Yes,
Yes, sir.
now we can see.
Yes,
And you
yes.
can switch to
So again,
presentation mode, sir. You can
again,
switch
let
switch to
me,
the,
thank you.
you can
Switch to
enlarge your
slideshow
slide.
mode.
Yeah.
Slideshow
Again,
mode.
let
Yeah.
me emphasize on you, every normal person is going to conceptualize four different approaches: visual approach, auditory approach, kinesthetic, and auditory digital. Let me explain you. Auditory digital is a logical approach. So every person is carrying four type of ways to get the communication. But here is very important thing. According to the founder of this NLP, who is Richard Bandel, who says that every person prefers one of the four modalities. Every person. So some students are preferring visual input, some students are preferring logics, some students are preferring auditory information, some are really kinesthetic. So it is important to understand, if we understand what is the modality of the specific student, and if we teach them in the same way, he will got more information, he will be able to conceptualize in a more best way. So here is a question: how we can understand a specific modality of a person? There are, let me give you two approaches. The first approach is listening predicates. Suppose if a student is sitting in front of you, you are having a, so the first thing is try to understand what kind of words he or she chooses. So predicates mean here words. So if you understand the choice of the words, you can understand the preferred modality of the students. And then you will be communicating in his or her preferred modality. And in this way, he or she will be getting more information because you are giving all the knowledge at her capacity. And then you will be able to program according to that student. So the first approach is listening to the predicates, and the second is looking at the physiology. Physiology means how the student is sitting, how the student is breathing. So you can decode the preferred modality of the student through looking at the body physiology. So I will be sharing you different important tips how you can decode a preferred modality of the students. So let me give you few information about the predicates. For example, if there is a person who is preferring visual information, he will be using words like images, see, look, view. So he will be choosing specific words that indicate some image, that indicate some visual. So his priority will be to use a word. For example, have you heard ever a person who is basically try to speak to you, but he is saying, look, there is nothing to look, but why he is choosing to look? Actually, he's going to say something to you. He's going to say a few words to you. But again, he is saying, oh, look, that means his preferred modality is the visual modality. And in the same way, the auditory person will be using sounds like words. Like, for example, if I'm going to buy this cell phone, have you heard somewhere, oh, take it, it sounds good. But there is no sound. It is not sounding, but it is looking basically. So why he is going to choose sound? Because he prefer more communication. He prefer ears to get the concepts. So again, the third type of modality you can decode, it's the kinesthetic preferred modality. The person who prefer kinesthetic, I mean, who are emotional, they will try to use the words like feel, touch, grab. So he will be preferring, like, have you seen somebody's status on the social media? And if he is in Islamabad, then he is like the status is like feeling awesome at Monal. That means why he has chosen to the word feeling. So that means he or she is preferring kinesthetic approach to get the information to communicate. So in this way, the fourth kind of modality is the auditory digital. So the people who are using words like logically, technically, let me think, then I will respond. So basically, that person seems a very logical person. So he will be going to review the information. He will be using word like review. For example, if I'm going to suggest, uh, please, you can buy this cell phone. I'm going to suggest, and if you are an auditory digital preferred modality person, you will see, oh, okay, let me see how about the specs and the things, because he or she will be more focusing on the specs, and he will be going to review this specific product on the Google. What people say, he will be focused on research, because usually the people who are doing research belongs to this category. It is not necessarily, but it seems, because when they spend more time in the research things, their mind also become research minded. So this is the way through words you can decode a specific modality of the person. And another way is the looking at the body physiology. Uh, Again, this is also a test. This is also based on the words. So you can use this test. This test is called as preferred modality test. So this is a scale basically. So you can use also scale to identify a specific person. It's a very simple scale and you can use this. But if I go on next through looking at the body physiology, let me also give specific information for those people. For example, if there is a visual preferred person, what are the basically characteristics you can see, you can witness on his body or her body? So the visual preferred people usually are organized because they want people to look at them. So this is the reason they are they're organized. They will try to speak louder because their subconscious mind says that the people should look at me. So every time they are going to learn through the faces. They can forget your name, but they will remember your faces. So they will be speaking loud. They will be like their posture will be upright. They will looking in the front like that, so that they can visualize lot of space in front of them. So they remember faces, but they can forget the names. So if you ask from the students, they might say that they are not, yes, they are not disturbed by the noise. Suppose if they're sitting at home and there is like any function going on in the neighbors and the student is listening the music and the things, but his focus on studies will not disturb because he is preferring vision to learn the things. He's not using ears. So this is the reason these people look like that. And if you want to train such people, if you want to train those people who prefer visual modality, so you can use visual things like flip charts, overhead, you can show graphs, you can show maps, drawings, picture, and they will learn in a best way. If your class, if your class students are with visual modality, and again, the next preferred modality is the auditory preferred. You can identify these auditory preferred people. They are easily going to distracted by the noise because their preference of learning is through ears. So if you will disturb through noise, they will disturb because they are more depending on the sounds, and they learn through discussions because discussion is obviously through sounds. So they will try to speak more. They are more expressive. So if you want to learn these students, you should discuss with them. They will not pick the things in a very small bracket form. You need to describe in detail because their habit is to listen more actually. So they will even ask you more questions again and again. So if you want to guide them, to train them, to teach them, please make them more discussion with them. They will ask you question and you should respond as much as question you can because otherwise they will annoy with you. As a teacher, they will not like you because they like discussion, but you're not looking at the discussion. So you need to get flexible according to the audience, according to the students, I mean. So in the same way, there is a third type of modality. This is called kinesthetic modality. These people are very emotional. Usually, if when they will sit, they will not bother the ethics. They will sit in a way, the way they like. They are not sitting for other people. And in the same way, they will not dress for people. They will dress for themselves because they want comfort. Emotional people, they are not bothering people. What will people say? They they choose what they like. Not like visual, because visual people dress for people, not for them, because they want to show the people. And the most important physiological sign is that they speak slower. They try to speak slow. And when they want to sit, and if you want to see, their breathing is coming from the belly. So if there is a male, so the tie you can move it, you can see the moving tie because they will be breathing from the belly, and you can even count the breathing rate as well. So this is the way you can identify the kinesthetic people. And let me give you the way how you should teach kinesthetic students. Like role play, they will like role play because they want to sit with other. They will like assignments in groups. So if you have a if you can mark 10 students in a class who are kinesthetic, you can make a group for assignments. They will like. They will not like actually the assignment. They will like you. You will be favorite teacher because you can understand them, how to teach them. So they will like role play, discussion, socialization in group teaching. They will like. So you can identify the kinesthetic group and you should teach according to their preferred modality. And the last, there is audio digital modality. And as I already told you that such students are really logical. So if you will give some concept, such students will be raising hand that what is the rational behind. They are always looking for the rational logic, technical background behind that. And such student basically like research paper. They want to read something, they want to review something. So if you have students from other digital modality, you can give them such kind of assignment. Please take this review article and please review it again and write a kind of report on that article, limitations, weak areas, good areas of that paper. They will enjoy such kind of assignments as well. So what happens? You may ask a question. Question is that I can answer one question, obviously. So you can ask a question that our class is of 100 students and teacher is only one. So while sitting at the podium, standing at the podium, so what way we should prefer to teach them? Because there will be students from every kind of modality. So let me answer this question. You should prepare yourself in 4 modalities. Try to make your presentation so visual that visual audience should be attracted to you. Then while you are teaching the visual presentation, then also get emotional at some time of point. And the emotional category of the student will be aligned with you. And in the same way, in every class, try to have a small discussion. And when you will discuss the thing, your auditory group of the students will be also liking you. And don't forget to give logical points where it is necessary. And the audio digital group of the students will also like. So in this way, you can be the ideal teacher. So I hope I was able to deliver a concept in a very brief period of time. However, this is a very big art. It's a kind of certification of at least, if I continue, it will take 7 to 10 days to complete all the NLP procedures and all the NLP techniques. Any
Thank you so
question,
much,
please?
sir. This was a highly innovative, some new learning
Sure.
that has taken place. Thank you.
Thank you. Thank
Thank you
you.
so much, sir. Now it's turn of cooperative learning in medical education by Dr. Hania and Dr. Hiramoy. Uh, can you please share your presentation?
Hello, am I audible now?
Yes, you're audible.
Thank you. So I'm just gonna continue. And today, Dr. Hiramoin and I will be sharing a small but a meaningful exploration into how a structured group learning, specifically the jigsaw technique, can help enhance the undergraduate medical classroom. And any questions that you have, they will be answered at the end of the presentation. Okay, next. All right, so medical education is undergoing a significant shift. The traditional lecture-heavy models, they are being replaced by more active student-centered approaches. And these aim not only to enhance the knowledge retention, but also to foster essential clinical skills, particularly in communication and teamwork. Now, why is it necessary? Well, because strong teamwork, although it is a vital component in the clinical practice, but oftentimes it's one of the places where healthcare professionals seem to struggle. And this study, it stems from that very gap. Next. Now, small group discussions, they sound great in theory and they're widely used even now. But in practice, they don't always deliver their intended benefits, and we often face three main hurdles. The first being unequal involvement, in which some students they participate actively while others they remain passive, and this leads to unequal contribution. Next, we have group dynamics. Now, teams they often face imbalances. There are some dominant voices, and they may overshadow quieter ones. The third problem that we noticed was lack of collaborative skills. Now, many students they simply haven't been trained to work collaboratively, and just grouping them together without guiding them or the required experience, this doesn't guarantee a very productive discussion. Okay, next. Now, these challenges they call for a little more structured approach, and that's where the jigsaw technique comes in. It's not just group work, it's a guided and a structured group work where the students they depend on each other to complete the learning puzzle. And this involves dividing the content into sections like a jigsaw puzzle and then assigning them to each group so that the students they can become experts on them. Then we rearrange the students into new groups where each student is required to teach their piece to the experts. Okay? This approach this not only promotes teamwork but it also enhances the understanding through peer teaching, and this is an effective method for deep learning. Okay? Next. Now, our study, this has two main objectives. First is to introduce the jigsaw model to undergraduate medical students and then assess its impact on their academic performance. Our second is to evaluate perceptions of both the students and the faculty regarding the use of this method in a medical classroom setting. Now I will hand it over to Dr. Hira Moin.
Yes, Dr. Hira, could you start the methodology?
Greetings, everyone. Am I audible?
Yes, you are audible.
Yes.
Okay. Thank you very much, Dr. Hania, for starting the presentation and explaining the brief introduction of our study that we conducted. I'm Dr. Hira Moin. I'm currently working as assistant professor in the Department of Physiology, NUST School of Health Sciences, National University of Sciences and Technology, Islamabad. So I'm going to further discuss the methodology and the results that we obtained in our study. So firstly, moving on to the study design, it was an explanatory mixed method design that was used by incorporating both qualitative and the quantitative components. In context of the quantitative components, we used a quasi-experimental design to assess the effectiveness of jigsaw technique by employing a mini assessment at the end of our study. Additionally, the perceptions of students were also gathered utilizing a Likert scale type of questionnaire that was validated, and it has 13 quantitative questions. For the qualitative component of this study, there were certain questions in the students' feedback questionnaire that were open-ended, so they were included in the qualitative component of the study. In addition to it, we had focus group discussion sessions with the faculty members, and that was a qualitative component of our study. So moving ahead into the methodology that was employed in our study. Firstly, this study was conducted in the neurosciences module for second year MBBS students. There were 2 sessions conducted, and the duration of each session was 2 hours. The topics in which this technique was employed were tactile position vibration sensations and pain and temperature sensations. Both of these topics were interrelated. So there were 100 students in the class, out of which only 80 participated in the study. And this number is due to the fact that the students who participated in the jigsaw session and who took the assessment at the end of the session were only included in the study. So what happened next was that the learning objectives were shared with the whole second year MBBS class 3 days prior to the session. And in this, they were allowed to prepare those learning objectives. However, after that, a large group interactive session was held with the students in order to ensure standardization for all students. And after this large group interactive session, the students were divided equally and randomly into 2 groups. One was the control group, and the other was the jigsaw experimental group. And this grouping was based on gender, ethnicity, and academic balance, and diversity was taken into consideration in this context. So, for the control group, they underwent the traditional small group discussion format that was regular faculty guided small group discussion. In that, there were almost 12 to 13 students in each small group. And for the jigsaw experimental group, uh, that was actually the experimental group. We used 2-phase approach to encourage student collaboration. First was the preparation phase, and the other one was the discussion phase. So in the preparation phase, as being depicted in the diagram, students were divided into 7 expert groups with 6 to 7 diverse students in each groups, and they were based on gender, ethnicity, and academic performance as we previously employed while dividing the class into 2 equal groups. So then each expert group was allotted 2 to 3 learning objectives. They were given 60 minutes to work together and compare their ideas and prepare those learning objectives and actually become the experts of those learning objectives. And they were also assigned a color code as depicted in this diagram as well. So after 60 minutes of preparation phase, the student moved to the jigsaw discussion phase. And in this phase, the students switched according to their color coding. So one student, can we like stop for a few seconds due to Azan?
Yes.
Yes, I would like to pause for 1 minute.
Okay.
I'm sorry for the interruption. Thank you all for waiting patiently. So I was explaining the methodology of the study. We were through the preparation phase of the study of the Jigsaw experimental group. Now moving ahead in the discussion phase of the Jigsaw experimental group. After the 60 minutes of preparation, the students, they move to their Jigsaw group based on their color codes. So one student from each expert group was a part of the subsequent Jigsaw group. Jigsaw discussion group had members who were experts of their own groups. So afterward, the student presented and they explained their topics to their fellow members of their group. And in the meantime, the other students, they listened carefully and they asked questions and they had a discussion. So this activity was conducted in a lecture hall, and the groups were sitting in the same lecture hall, and they were supervised by 4 faculty members that were moving from one group to another to resolve any queries during the discussion phase. So same activity was conducted for the pain and temperature sensations, but we reversed the group. The crossover design was employed. So initially, those students who were included in the control group were then part of the Jigsaw experimental group, and those who were initially part of the experimental group were included in the control group. When both of these sessions were conducted, we took an assessment that was an MCQ-based assessment, followed by the feedback, and the MCQs were that were included in the assessment were usually based on C2 and C3 level of Bloom's taxonomy. So after the conduction of these sessions, the evaluations of student perceptions were done by administering a questionnaire after informed consent. It had 2 sections. Section 1 was quantitative, having 13 Likert scale type questions, evaluating the acceptance of the Jigsaw technique, the interpersonal skills that the student think they developed during the whole process, the positive interdependence and comparison with the typical small group discussion. In the section 2, we employed the qualitative component, and there were 3 open-ended questions evaluating the positive and the negative aspects of the activity according to the students and their suggestions for the improvement. And this questionnaire was initially validated by the experts, and it was piloted for on 15 students prior to its use in our study. And the Cronbach alpha value that was evaluated was 0.95. So the faculty perceptions were evaluated through the focus group discussion session using a semi-structure open-ended questionnaire. After the collection of the data, the analysis was performed using SPSS version 22, that is for the quantitative component of the study. The assessment score percentages were expressed as median and interquartile range, and the comparison between the groups was done by utilizing the Mann-Whitney test. And this non-parametric test was used because the data was not normally distributed. In addition to it, the questionnaire responses were evaluated utilizing the descriptive statistics. And finally, for the qualitative component, we employed the thematic analysis and identified different themes and sub-themes. So moving ahead onto the results section, firstly, the quantitative findings. As depicted in this diagram, you can clearly see the assessment score percentages that were recorded for control and Jigsaw experimental group. The median score in the Jigsaw experimental group was significantly higher as compared to the control group. The value of significance was 0.003. So it implies that Jigsaw technique was effective in improving the academic performance. In addition to it, we analyzed the data in a manner that we evaluated the percentage of the students scoring 60% or more marks in their mini assessment. So this result was also significant. 71.3% of the student in the experimental group, they scored 60% or more marks. And in the control group, there were 50% of the students that scored more than 60% or more marks. So in this particular context, Jigsaw technique was also effective because overall, there was a greater number of students who secured more than 60% marks after undergoing this Jigsaw technique. So in context of the responses recorded for the questionnaires items, The first diagram that is labeled as A represent the acceptance of the jigsaw technique. So this graph shows the responses of the students regarding the questions on acceptance, and they show that this technique was very well accepted by the students. Now, the diagram B represent the questions related to the positive interdependence. I would like to slightly define this positive interdependence, that it is a component of the cooperative learning that signifies that participants in a group, they work as a team to achieve a common goal, and the questions regarding that also received a high degree of agreement from the Likert scale. So moving ahead on the C diagram, it basically represents the responses of the students regarding their perceptions on improvement in personal and interpersonal skills. So the most of the students agreed or strongly agreed that this technique enhanced their critical thinking, improved their communication skills, and helped them in becoming an effective team member. So regarding the perceptions on comparison with small group discussion that was traditionally followed at our institute, all the elements, they show high mean values for all items. So after that, we recorded the qualitative findings that were also a part of the questionnaire for the students. So this diagram is depicting the positive and the negative feedback that was identified through the thematic analysis for the open-ended questions. So the positive aspects that were identified, that students believe that this technique helped them in better comprehension of the concepts. It was well structured and well organized and aided them in learning in a better way. It was creative. It created an inclusive learning environment because each and every student got a chance to equally participate and present their ideas and the concepts. It was a very effective group discussion for all the students, and it was learner-centered and active learning strategy. So negative aspects include that the students said that it was time intensive, it was longer as compared to the traditional format, there were insufficient logistics, and they were afraid a little bit and they were apprehensive about the fact that they had limited faculty supervision and they might perceive the concepts wrongly. And they also told that there were certain students who were not prepared. So faculty also identified a number of benefits to the students as well as faculty. This diagram is showing the feedback of the faculty members in the focus group discussions. And there were a lot of points in terms of the better learning for the students, decreased workload for the faculty members. However, there are few certain disadvantages that were identified by the faculty members, such as fewer students were attentive throughout the session. So it might not be that much regulated. So these were the certain points in the feedback of the faculty members. So moving ahead, because we have certain time constraint, overall it was a overall faculty perceived it as a good technique that can be incorporated in the undergraduate medical learning to improve or enhance the learning of the students and even their communication skills. So limitations of our study included that it was limited for only 2 topics in neurosciences module and it was conducted in a single institute. So in order to generalize the results, we need a larger scale implementation of this technique and then evaluating the results of this technique on the academic performance of the students. Additionally, we didn't evaluate the long-term knowledge retention effect of this jigsaw technique. So that our study lacks in this as well. So we would like to recommend that future studies should incorporate these components, a larger scale implementation of the jigsaw technique and evaluation of the long-term knowledge retention. So the conclusion of our study is that the jigsaw method is associated with higher level of academic performance among the second year undergraduate medical students as compared to the typical small group discussions. Furthermore, the students reported this technique to be effective cooperative learning strategy that promotes in-class student engagement, active participation, and sense of inclusivity. So also the faculty members found this activity beneficial in terms of promoting active learning. So the take-home message that I would like to mention here is that just this jigsaw technique is an active learning strategy to promote in-class student engagement, as collectivism is always better than individual intelligence, which would always result in better academic attainments.
Thank you so much. Thank you
Thank
so
you.
much, Dr. Hania and Dr. Hira, for presenting your jigsaw technique and enhancing students' learning in the classrooms. Now it's turn of Professor Dr. Nadia. Professor Nadia is from Bangladesh, and she is going to present integrated teaching in the first phase of MBBS curriculum 2021 in Bangladesh. Professor Nadia, would you like to share your slides? Yeah, we have to share your slides. Would you be able to share your slides, Professor Nadia?
Yeah, I'm sharing.
Okay, okay.
Can you see the presentation?
No.
Can you see it now?
No,
Still
Dr.
not?
Nadia. Still not.
Dr. Nadia, can you click the share button? It is next to the leave button, the icon, arrow headed upwards.
Yeah, I have clicked that.
And after that, you will just share your presentation. You will be able to do so. You will be able to share your screen even. And after sharing your screen, whatever you present on your screen, we'll be able to see that. So if you have minimized your presentation, you can directly open it up. Otherwise, you can use the share screen option, and then anything you will show, we will be able to see it.
Yeah, I had minimized it. Now I have opened it, but can you see it now?
No.
No.
Have you clicked the share button at first?
Yeah, I have selected that.
Dr. Hira, would you like to share that presentation? I think we have the presentation of Professor Nadia.
Okay, I'll share it, ma'am.
Great. Then you have the backup you will open at your end. I must say that all the presentations are so interesting and engaging that I cannot get up from my sofa. I'm taking notes throughout.
You are right.
Thank you, Professor Munajja, for introducing me. I have a little correction. My designation is not professor. I am a lecturer of Manikganj Medical College.
Okay.
Am I audible?
Yes, you are.
And one day you will become professor.
Inshallah.
Inshallah. So all those teachers who have presented their original research, they are offered to please publish, write down their research in a format of a research journal and do publish their presentation. in the form of a manuscript.
Yes, now it's visible.
Great. You can switch to presentation mode where your cursor is right now.
Can you see it now?
Yes.
Yes, yes.
Okay, thank you. As today's webinar is entitled Innovative Techniques in Teaching and Learning, so I am eager to give a glimpse of how we teach integrated teaching in a limited scale. In MBBS curriculum 2021, 102 topics are incorporated for, next slide please. Yeah, thank you. In MBBS curriculum 2021, 102 topics are incorporated for integrated teaching, which can be either in horizontal or vertical or in both method of integration. In first phase, we have 12 topics that is taught in anatomy, physiology, and biochemistry. These topics are coronary artery disease, COPD, anemia, diabetes mellitus, diarrhea, jaundice, electrolyte imbalance, proteinuria, thyroid disorder, cerebrovascular disease, deafness, and errors of refraction. Next, please. So I'm going to discuss briefly about the techniques we employ to teach coronary artery disease through collaboration among the departments of anatomy, physiology, biochemistry, cardiology, and pathology. It is a 3-hour session, and at the end of 3-hour session, we expect the students will be able to explain the pattern of artery, supply of heart, describe the coronary circulation and regulation, explain the appearance and disappearance of cardiac markers, and this knowledge of blood supply of heart obtained in this phase to correlate in real life situation. Next, please. The core contents of this session are peculiarity of coronary circulation and its regulation, nerve supply of heart, and nature of referred pain. These two topics are taught by the Department of Anatomy. The Department of Physiology teach balance between supply of blood and demand and ECG changes in ischemic disease in short, and also the regulation of coronary circulation. Biochemistry department teach about the cardiac markers. Then cardiology department teach the ECG changes in ischemic disease in details, and if pathology department is available, they can teach the pathology behind these ischemic changes. Next, please. So at first, we emphasize that why should we know about coronary artery disease? We teach the students that this is the leading cause of death worldwide, and in Asia, the rates of coronary artery disease are rapidly rising. And almost all elderly people have at least some impairment of the coronary artery circulation nowadays. And once developed, it has devastating effect on quality of life and is responsible for 10% of disability adjusted life years in low income countries and 18% in high income ones. Next. So before divulging into the ischemic heart disease, we have to teach the students the normal coronary blood flow, and it is about 4% to 5% of the total cardiac output, and during strenuous exercise, it increases 3 to 4-fold of normal flow. This figure is important for the students because of the pattern of coronary blood flow in the cardiac muscles. This figure shows the epicardial coronary artery, subendocardial arterial plexus, and the intramuscular branches of these arteries in the cardiac muscle. Next. In this figure, we show them phasic flow of blood through the coronary capillaries in the left ventricle. Here, during systole, coronary blood flow decreases from the normal level of about 225 ml per minute to as low as 100 to 80 ml per minute, and due to a strong compression of the intramuscular blood vessels by the contracted muscle. And during diastole, this blood flow increases up to 300 ml per minute because of relaxation of the ventricle, and thus no longer obstruction of blood flow occurs through the left ventricular muscle capillaries. Next, please. Then we have to taught them about the importance of coronary blood flow. Here, local muscle metabolism is the primary controller of coronary flow. The more the muscle metabolism occurs, the more vasodilator substances are produced, and the more coronary blood flow occurs. Also, there are some other vasodilator substances present in the blood which causes increased coronary circulation, and some vasoconstrictors causes vasoconstriction and thus decreased coronary blood flow. In the nervous control of coronary circulation, indirectly sympathetic stimulation increases heart rate, blood pressure. As a result, metabolism increases and vasodilator substances are produced, which causes vasodilation and increased coronary blood flow, while parasympathetic stimulation decreases these activities. Next, please. So, after explaining the blood flow through the cardiac muscles, we have to give them this concept of balance between supply of blood and demand of cardiac muscles. Normally, oxygen supply occurs in accordance to the oxygen demand due to metabolism of the cardiac muscles. But in myocardial ischemia, either oxygen supply is decreased or oxygen demand is increased. Whenever this disproportionate distribution occurs, myocardial ischemia can occur, which can lead to myocardial infarction. Next, please. This table shows the factors influencing myocardial oxygen supply and demand. Oxygen demand increases due to cardiac work, that is during increased heart rate, blood pressure, increased myocardial contractility. In some pathological diseases like left ventricular hypertrophy, valvular disease, etc. And oxygen supply occurs in accordance with coronary blood flow. The more the coronary blood flow, the more is oxygen supply, which occurs during duration of diastole due to relaxation of the ventricular muscles and less obstruction to the coronary vessels. Also, coronary perfusion pressure affects coronary blood flow. The more coronary perfusion pressure, the more coronary blood flow and the more oxygen supply occurs. Coronary vasomotor tone causes increased vasoconstriction. As a result, coronary blood flow decreases and oxygen supply decreases. Also, oxygen supply depends on hemoglobin concentration and oxygen saturation. Next, please. So when this imbalance occurs, ischemic disease develops, we use ECG changes to for diagnostic and prognostic purpose. ECG is used to assess cardiac rhythm and conduction and myocardial ischemia and infarction. We teach them that the causes of ischemic disease can be either changes in the diameter of a vessel or reduced blood supply in spite of normal coronary anatomy. When we talk about the changes in the diameter of a vessel, we give them a glimpse of Ohm's law and Poiseuille's law, how those laws teach us the relation between the diameter of a vessel to the blood flow. And this change in diameter of cardiac vessel can occur due to atheromatous plaque, which can cause partial block. When this plaque ruptures, complete block occurs due to superimposed thrombosis. Also, coronary spasm can cause ischemic disease. Reduced blood supply can occur in anemia or in hypovolemic shock, etc. Next, please. So before teaching them the changes in ECG, we have to teach them the normal ECG. And we teach them about these waves, P waves, QRS complex, T waves, ST segment, PQ segment, etc. At their normal value, isoelectric line, etc. And which wave or segment denotes which phase of cardiac cycle. Next, please. So we show them this figure showing generation of ECG graphs. Here, in figure 1, it is before atrial depolarization. In figure 2, the node starts discharging action potential automatically and spread in the atria. As a result, atrial depolarization occurs and P wave is produced. After that, AV nodal delay occurs, which is about 0.09 seconds, and as a result, PQ segment is produced. After that, the impulse goes to the ventricle and ventricular depolarization occurs, and as a result, we get QRS complex, which is about 0.08 to 0.1 second. After that, plateau phase of ventricular action potential causes development of ST segment, and T wave occurs due to ventricular repolarization, which is about 0.35 seconds. Next, please. So these abnormalities of imbalance between demand and supply produce the diseases which can be, in short, is called as coronary artery disease, which include stable angina, unstable angina, myocardial infarction, heart failure, arrhythmia, and then sudden death. All of these clinical problems are related to the pathology of ischemia due to atheromatous change, which can be fixed atheromatous or ruptured atheromatous or with superimposed thrombosis, etc. And at last, if these are not corrected, then ventricular arrhythmia, asystole, or massive myocardial infarction may occur. Next. So in myocardial infarction, we teach them to grossly to see these three things, that is whether ST elevation is present, Q wave is present or not, and T inversion is present or not. And we also teach them to see on ECG about the site of infarction, whether it is anterior, inferior, septal, lateral, or posterior, whether it is recent or old in relation to the presence or absence of pathological Q wave, and whether it is ST elevated myocardial infarction or non-ST elevated myocardial infarction. Next, please. In this figure, we show them from now on, we show them different ECG tracings of different types of myocardial infarction. In this figure, we show them about the recent anterior non-ST elevated MI, and here you can see that, or they can see that T wave infarction is present in leads V1, V2, V3, and V4. Next, please. In this figure, we show them about the acute anterior MI, where the patient arrived with history of severe chest pain 6 hours earlier. Here they see the ST elevation in leads 1, AVL, V2, V3, V4, V5, and V6. Also Q waves in V3, V4, and V5. Next, please. In this figure, we show them acute transmural inferolateral MI, where the patient arrived with history of severe chest pain for 4 hours. Here, ST elevation is noted in inferior leads 2, 3, and AVF, and the lateral leads of V4 to V6. Also, reciprocal ST depression in leads AVL and V2. Next, please. Next, please.
I'll change it to the next slide. Is it visible?
Yeah, now it is visible. Thank you. In this figure, we show them inferior MI, where the T wave inversion is noted in lead 2, 3, and AVF. In the next slide, please. We actually teach them to detect the abnormal waves in different ECG tracings. Next slide, please. Yeah. In this figure, the A is normal ECG wave. In the B, there is a acute ST elevation, which occurs within minutes. In stage C, there is progressive loss of R wave, and there is Q wave. There is loss of T wave inversion, and it occurs within hours. And in figure D, there is pathological Q wave development, T inversion, which can occur within days. And in stage E, pathological Q wave persists and T inversion decreases, which can occur after several weeks to months. This is the serial evolution of ECG changes in transmural myocardial infarction. Next, please. So we present at first anatomy department present the anatomy of the heart, then physiology department present this presentation, then biochemistry department present the myocardial markers, and after that cardiology department gives presentation in details about coronary artery disease, their signs, symptoms, ECG changes, or other investigative changes. And then pathology department can give their presentation on the pathology behind them in details. After that, we give them at the end of all these presentations, we give them real-time scenario or problem-based questions. A written assessment is conducted, then marking is done. Further, problem-based question is prepared in summative assessment from these topics. Thank you.
Thank you so much.
This is the end of my presentation.
Thank you so much, Dr. Nadia, for elaborating whole integrated teaching concept on coronary artery disease. Now our next presenter is Professor Rita. Professor Rita will talk about innovative ways of formative assessment. Professor Rita, have you joined?
Yes, I'm here.
Would you like to share your presentation?
Yes, I'll try. Okay.
Hi, Professor Rita.
Hi. Hi, Professor.
Hi, good to have you finally. Can you please speak loud? We know that you have a very sweet and soft voice. Can you please speak loud?
Oh my God. Thank you. Is it visible?
Yes.
Is it visible?
Yes, it is visible.
Yes, please switch to presentation mode, slide mode.
Yes. Is it now okay?
Perfect.
Okay. So, good evening, President of SAAP, Professor Samina Malik,
Good evening, my friend.
and moderator of this webinar, Professor Munaza, and
Good
dear all
evening. Good
are
evening.
present over here. So today I'm going to present a topic on innovative ways of formative assessment. So as we know that this formative assessment is a process used by teachers to monitor students' learning and provide ongoing feedback to improve both their teaching and learning skills. Now, this term, formative assessment, was first coined by the Michael John Stephen in 1967. He coined both formative and summative evaluation in his book, The Methodology of Evaluation. Later on, Benjamin Samuel Bloom, he took up the term, just a minute. Okay, so took up the term in 1968 in the book Learning for Mastery to consider formative assessment as a tool for improving the teaching learning process for students. But what happened that its impact on learning was not accepted for several years. Later on, based on the several research outcomes, it was added in curriculum. So let's see that what are the differences between summative and formative assessment. When we see the formative assessment, we find that it helps students to learn and practice, while summative assessment assess student performance. And when we see that when formative assessment, then we find that it is throughout the course, and summative assessment at the end of the instructional period. Now, why to do formative assessment? So it is actually to identify gaps and improve learning of the students. And the summative assessment to collect evidence of student knowledge, skill, or proficiency. Now, when we go for how, then we find that it is via approaches that support specific student needs. And summative assessment exists, that is via exit learning products or cumulative assessment. So as we know that undergraduate medical curriculum has been changed to competency-based curriculum now, and the main aim of this curriculum is to focus on how learners apply their competency, that is knowledge, skills, and attitude for the academic or the practice of medicine. So the main aim of this newer curriculum is to make the learners gaining each competency starting from novice to mastery. And thus, the educational process that is mainly focusing on formative assessment. So this formative assessment, that is as it is taking from novice to mastery, it has some steps starting during the course of the learning. There are 4 questions answered by formative assessment from starting from the novice to the mastery. So first step, that where is the learner now and where is the learner going? How will the learner get there, and how will the learner know they are getting there? So how can we assess these all things, and how can we make a student competent? So there are certain tools, following those we can do, and those are the various tools used for the formative assessment. So in formative assessment, when we see that we all are doing several formative assessment during our course of learning, teaching. So in that case, one is the self-assessment. And self-assessment, most of through the questionnaire in any based like in the community or about self, that is using the questionnaire self-assessment. Other is the peer assessment, and the most important is the feedback from the teachers. In addition to that, what we can see that at certain level and certain time we use quizzes, and those are also under the formative assessment. So here we can see that in one study for the practical classes, they have conducted like laboratory practical and quizzes first in first week, and then later on formative questions are available for the students for the certain times of this. Then they got next day, that's the feedback, and again repeated the same thing. And after repeating of this, they just conducted summative examination to see the effect of this formative assessment, that how students are improving. So, but in all these tools, what do we find that the feedback is becoming most effective. And why it is? So according to the Sadler, any kind of feedback is powerful for the several reasons. First, it informs teachers about level of knowledge, understanding, and skills attained or yet to be attained by the students. Second, it aims to facilitate learners in being able to identify and amend a gap in learning. Third, it assists teachers in reducing and selecting suitable tasks or activities. And fourth, it allows teachers to modify their teaching in order to support and closing of the learning gaps. So, and along with that, that the peer and self-assessment is essential to learning, because a student can really achieve a learning goal if they understand the goals. So why this effect, that's the among the all tools, feedback is most effective, because when we see the feedback, then this is timeliness. Whenever that anything is being presented or anything is demonstrated or given, at the same time feedback is given, and that's why it is productive, because at the same time if they are getting feedback and also the feedback constructive, so that student can get it easily and improve their gaps. So constructive means so, and the other, so that somebody is talking, so that there is the direct relationship to assessment criteria and learning outcome, and is the tool feedback is becoming the most effective for the formative assessment. So effective format, that's the role of feedback in the learner's writing quality, has received considerably less attention than it deserves. So what is happening that most of the feedback is just the improving knowledge part of the, that is the cognitive domain of the student, but cognitive and other is the more listening and other part, but the writing part is getting less attention. Other is the skill, that's the impact of formative assessment on learning skill has also received less attention. So today's in this talk, I'll discuss more about these two parts of the student, that is learning through innovative ways of formative assessment. One is the writing quality, how can we improve, and other is skill of the students related to their practical and other. So first is the a system of feedback on student writing, and it was it's just that the discussion held on students mock and an examination, a unit examination. This is the innovative type of feedback, and that's on the question answer between respective students and teachers, and feedback was given to each student for proper and complete writing. So this kind of feedback on student writing was first started. It was introduced in BPKIITs, BP Koirala Institute of Health Sciences, Dharan, in 1994, and in undergraduate medical students. So how it was, because when we say student that writing anything, then they may give more, some can give more attention or some can give less attention. But when it is related to the examination, then obviously they will give full attention. So that this was introduced in BPKIHS, and since that is 1994, how it was done. It was for the feedback, date and time was already scheduled in their course schedule. Then when mock examination or end unit examination were held, then first the copies collected and sent to the examination department, and then from examination department the copies were all answer sheets were sent to the department, to the respective faculty and teachers for correction. And after correction, the all answer sheets were sent back to the examination section, as usually we do. But later on, what were done then, corrected all answer sheets of concerned subject with marks were sent from the examination section to the classroom on that scheduled date of feedback. Then all these question answer sheets were distributed to the respective student by teachers, and students, all students, they read their own answers, and then students discussed these answers with their teachers, that why they are getting such marks, why not more, and where is the deficiency. So all those. So it was really a brainstorming session through which students used to learn how to write answers properly and completely of any question. And through this brainstorming session, actually they could learn that how to write in a complete manner. And after that, all these answer sheets were collected and sent back to the examination section. So this mock examination was fully, that's the formative assessment, only feedback based. But the end unit examination, what was the end unit examination? Summative marks were sent for the internal assessment, and feedback all was as a formative assessment for the student to improve their writing. So this was, but because of, though this was very effective, because of some, that's the difficulty, so many times returning questions, answer sheets, so it was stopped later. Now the same kind of formative assessment, a system of feedback, can be done in a different innovative way. And how can we do this? So the same kind of discussion of students' mock and end unit examination question answer between respective students and teachers, and feedback can be given on that, but in a bit different way, like excellent or 10 excellent answers, 5 average answers, and 5 below average answers of a question will be taken from the answer sheets and projected in typed way, projected anonymously in front of the student in classroom. Then student will be asked to mark those questions out of 10 with regions, so that all students can be involved for answering those questions. Which reason? Why? Out of 10, if anybody is marking 8, then why? If anybody is marking 4, then why? And so that so many reasoning can be learned indirectly and directly by the students. Then it will be really a brainstorming session for the students. Now after that, what will happen that the students will, the teachers will project the marks of that answers. Exactly how much marks is given to that, so that it will be, then student can compare and can discuss with the teacher that why such marks is given, and that in that session it will be a self-assessment session, because it will be a students will compare with their marks, and it will be a kind of self-assessment for the students, and they will learn the gaps and improve their writing. So in such a way we can improve student writing, understanding, filling the gaps, and whatever they are learning, they can write properly. Other for the skill, formative assessment we can also do for the skill or competency, in that can be done in practical classes of physiology. So, as I have taken one example as I do in my class also. So for example, BP measurement. Then how can it be done that BP measurement, as usually we brief. So the briefing will be done by the teachers and the demonstration by JR, resident. Then after that, task is given to students to perform themselves in a small group. So all students, suppose 100 students are, suppose 30 students are there or 50 students are there, then they are grouped. Suppose that 50 students, then 5 students in each group, and they are given task to measure their blood pressure in groups. Then after that, all groups, one group representative are asked, one from all group, these representatives are asked to explain methods, how they measured, and result, and present, both will be presented, and interpretation by all groups in front of whole class. Then so the main thing that we should not focus more on the results, whether it is increased blood pressure, decreased blood pressure, normal blood pressure, because this is the process of learning of the methods. So more focus on the methods, and for the assessment of methods learning process, so they will be asked more about the methods, what guidelines they followed. So, and after that, checklist prepared by the teacher will be projected, and then the students will go through the checklist, and then they find that where is which steps they followed and which steps they left, and then again students will be asked to measure blood pressure following the all checklist, and the checklist will be given to the peers, and peers will assess the blood pressure measurement method, so that when peer measure this assess blood pressure measurement, then peers also learn the how to measure blood pressure, and then who is measuring blood pressure, they will also learn skill, and repeated measuring, they will follow the either WHO guidelines and other guidelines of blood pressure, and they will learn competency. So in such a way I do in my practicals for ECG also, for the blood pressure measurement, for diet framing, for other WBC and RBC count. So in such a way, they are more competent for the method process, then the results and interpretation, and they are gaining competency about those skills, that is the clinical skills. So I found this is very effective way, because at the end of the classes, when we ask questions, they are very easily able to answer those questions. So in summary, formative assessment is a process used by teachers to monitor students' learning and provide ongoing feedback to improve both teaching and learning. Formative assessments act as a powerful instrument to improve students' achievements. Feedback is recognized as a crucial aspect of formative assessment. Student writing quality and learning skill can be improved through innovative ways of self and peer assessment with application of checklist and marking peers' answers. So thank you.
Thank you so much, Dr. Rita, for highlighting such an important topic of the impact of formative assessment on students' learning. Any questions or any feedback regarding all the presentations? Any question?
Will you allow me?
Yes, yes.
Okay, so starting from Dr. Udari. First of all, I would like to say that you kept me awake, very fresh, although I was fasting today, but I'm still sitting, and I have learned a lot by virtue of all the presenters. So all the presenters are going to be awarded by a very special certificate, inshallah. So the second thing is that regarding Dr. Udari, so one by one, Dr. Udari, very well presented. Are you there?
Yes, I am. Yeah.
Great. So you must get your study published, and I wanted to ask you that what about the disadvantages? You have mentioned the advantages of your study. I'm sorry, there is something wrong with my camera, so I'm unable to see make you see me. But I hope that we both can hear and listen to each other. So was there any disadvantage as well of your study, or what about the patient safety and the student safety when you give the direct exposure of first year medical students, when you expose them to the real patients? So do you think there can be an issue of student safety and an issue of patient safety? And what is your take on simulation, use of simulation PBL as the first exposure before exposure to the real patient? What about the students? They themselves act like simulated patients and give some exposure. Although the very valid point was about empathy, that you said that the students got sensitized to the patient issues, which is a huge achievement. So what's your take on the disadvantage component?
Yeah, actually, this is not really similar to the clerkship experience that the students are getting after third year. So always the preceptor or the teacher was with the students. Like when we were doing the it's like about 10 students and the preceptor or the teacher, and the teacher is always with the students. And whenever they are going to a patient, always the teacher is there. And like if the students do like to speak to the patient, they are allowed to speak while the teacher is present there, or like sometimes maybe just nearby. So and they were not asked to examine the patients until the teacher is there, and like teacher is guiding. Okay, now I'll show you how the fine crepes are like. You can auscultate this patient. Actually, these students do not have stethoscopes even. So only 1 or 2 students in the group have stethoscopes. So sometimes we are offering our stethoscopes to the students. So it is completely kind of a guided ward visit. The students are not really individually going to the patients and contacting the patients. So student safety wise, so patient safety wise, actually we didn't come up with such an issue. So we just gave them instructions not to get photographs, not to like do any procedures or anything like that. And student safety wise, I mean, if you mean like infections or like needle handling type of things, we never thought of.
No. Actually, it's by student safety. I meant that if the teacher scolds a student in front of a patient due to some behavior that is not expected by a mature doctor, and the student they laugh at different gestures of the patient, and sometimes they are unable to control themselves. So it is difficult to tame the students who are a first year medical students. So in this context, I was talking about student safety.
Yeah, to be honest, I didn't come up with a situation like that so far. No, nobody complained about some, because it's like these students are first year students, so they are like not really, I mean, not much cooperative with patients. They are still learning and still try to make kind of communication and things. So we didn't see actually they are like very forward and going to the patient and talking to them more like we were like really protective towards students as well when we were in the wards, and we understood that their situation and like they are still learning and they are just first stepping to the wards and even to government hospital. So actually, to be honest, I didn't come up with that type of a complaint from the other teachers, or even I myself have not experienced something like that.
Understood. It means that your students are really disciplined and they are very well carried by the teachers.
Yeah, at
Great.
least with the
That is
first
great
one
to
or
know.
2 years, they are disciplined. Maybe it's changing.
Yeah,
So they
that's
go to
great.
third, fourth, and final
And
levels.
maybe by use of simulation, we can improve the
Yeah.
exposure to the patients, because not all types of patients are present all the time in the ward.
Yeah.
So
Yeah.
some kind of dramatization can be
Yeah.
added in cases, especially when we lack those type of patients in the ward, and we need to teach them. So
Yes.
brilliant study. Brilliant. Thank you very much. Thank you very much. So can we move on? Thank you very much, Professor Rashid, for joining up and staying with us all the time.
Yes, thank you very much. Thank you very
Professor
much.
Rashid is the president of Pakistan Physiological Society. I'm also grateful to Professor Nema Sultana, the Secretary General of SAAP, for staying with us.
Thank you,
So
Professor Samina Malik.
thank you.
So,
Thank you. Thank you so much, and feel free to ask everybody. So next question to Dr. Hira and Dr. Hania, the team, the Jigsaw team. So the Jigsaw team, are you there?
Yes, ma'am, we are here.
May I know who was your supervisor?
Actually, I did this study in my CHP
That's a brilliant
certification.
study, and you must get it published, okay? And
Thank
it
you,
can
ma'am.
go straight to advances in physiology education. It can get accepted as such.
Thank you so
So,
much, ma'am.
okay, so do publish it. So my question is about your 9 experimental groups, if I'm right. So were the same
Seven.
LOs, you said 2 to 3 LOs were given to each group. So were they the same
Yes.
LOs for all the groups, or they were different
No,
LOs?
we divided the students, 40 students, into 7 groups, and each group had different LOs. So, one of the group that was a discussion group, they were preparing separate LOs. Other groups were preparing separate LOs. So, eventually, when they prepared during the preparation phase of 60 minutes, they were moved to their subsequent jigsaw group, and one member from each discussion group was actually the part of the subsequent jigsaw group. So they had different LOs to prepare for from the whole topic.
So my question is that if they had different LOs, so in that case, only one person in the jigsaw group was the master of those LOs, and the other
Yes,
ones were passive listeners, and he
yes,
was
yes,
actively or she was actively teaching them, right?
yes, yes.
And what happened when you reversed this? It was a crossover design. When you reversed it, the controls, what were the controls doing?
The controls initially in the first phase or in the first session, when the students that were the part of the control group, they were in the crossover design, they were then the part of the jigsaw experimental group, and the experimental group students in the first session were the part of the control group for the new topic, because we introduced this technique in two topics. First was a tactile position and vibration sensation, and the next topic was pain and temperature sensation. So we reversed the
Okay.
group in the second session.
Okay, so the best advantage, I believe, when you made that jigsaw group was that each student should contribute actively, isn't it?
Yes.
Without hiding under the shadow of another student. You expose them.
Yes, because in yes, definitely, because in traditional small group discussion sessions, usually some of the students they actively participate, and the other student don't get a
Right.
chance to present their idea. So that was
Right.
the main
So
reason that we implemented this.
you have aligned your studies with the problem. So that is a
Yes.
perfect study. That is a perfect
Thank
study. You must go for publication. Okay,
Thank you
thank you.
so much, ma'am. Thank
So
you.
my question to Dr. Farhana. Dr. Farhana from Bangladesh, are you there?
Yes, I am here.
Yes. Okay, your study was also very interesting, but I was wondering that you gave exposure to two types of teaching methodologies, traditional followed by integrative. Am I right?
Yes.
So what do you expect that after receiving both types of exposures, definitely the outcome or in the assessment would be better than a single type of exposure, isn't it? Wasn't it expected even at the start of your study?
Actually, what's happened that I have presented here my MD thesis work actually.
Okay.
I have my study participants are the phase 1 students of a government medical college in Bangladesh. So here are some limitations that as their schedule was so tight that I can't get any extra time to take the classes as well. So for these limitations, I have to I can't take the session by myself. In other studies which compared the traditional teaching and integrated teaching, they took different session and they examined different groups so that they compare the effectiveness. Actually,
So I'm right. So I'm very much impressed that you understand the limitation of your study, like a good medical educationist, and you can still publish it by writing the limitation that this was your limitation, that you could not study two different groups, but you had to study the same group. You had to work on the same group and give them one after the other, two exposures, right? So did you conduct the assessment after the traditional type of teaching as well, or you conducted it only once, that is after both types of exposure?
No, actually, I have taken. I have evaluated them 2 times after traditional session and after integrated session.
Right. So, and the traditional was the first to happen, right?
Yes, exactly.
Yeah. So still it is quite a good study because you have a baseline after traditional. You can compare, right? And you will mention this limitation, and it will get published.
Actually, in traditional session, they are not getting the clinical application. But in integrated session, they are approaching to the clinical application, so that in my study, I have presented that the clinical applicable level of question answering the clinical applicable level has increased after integrated session.
Yes, definitely. So that's wonderful. So get it published and do write your limitation as well, because it will add to the strength of the study. Okay. Writing limitation is actually a strength. Okay, great. So thank you very much. So next is Dr. Nadia. Are you there?
Yes.
Dr. Nadia from Bangladesh. Are you there?
Yeah, I am here.
Okay, great. So it was a beautiful idea to present this type of topic, which is very important, one of the common causes of death, coronary artery disease. And I was thinking that we can render topic-wise integrated recordings for YouTube channel of SAAP, so that the students who are preparing for the postgraduate exams and even undergraduate exams in integrated curriculum, they will be able to learn best from here, because the students, they are preferring these days learning from YouTube channels at their own pace, self-paced. And if great teachers like you, they are presenting them, then there will be no chance of mistakes, and they will have a good kind of revision after learning from the classroom, as Professor Rashid is very touchy about classroom focus and presence and eye contact and everything. So after that eye contact and everything, this can be a good source of revision. So, but I was thinking that instead of just doing the talking and didactic teaching in integrated curriculum, do you also, and I believe you do it, that you also project the diagram, like you projected in the beginning, a diagram from Guyton that was about the blood supply, coronary blood supply, and it was also mentioning the subendocardial layer. And there you can ask them a connected question that by looking at this diagram, what do you think is the most likely place of infarction in the heart? So then the students can directly relate the diagram with this logical question that subendocardial infarction will be more common because it buries down deep down. So when the heart contracts in systole, it is more likely to suffer from that. Likewise, deeper understanding of sympathetic and parasympathetic direct and indirect effect on coronary artery. Instead of telling them, I believe that you ask them to interpret a concept map and make the students, other students understand by discussion in the classroom among the students, by creating this discussion among the students about verbalizing it and interpreting how the indirect effects are more important. So I hope that this kind of teaching is taking place in the integrated curriculum instead of didactic. I hope that it is taking place.
Yeah,
Yes?
it's kind of, it's not totally didactic. It is didactic. It is an interactive session. We ask them questions during the presentation. They answer back. And we also give them the problems, the scenarios to explain the ideas, the concepts afterwards.
That's
and
wonderful.
then they
Because
submit the assignments.
that's wonderful. So
Okay,
because
can I share
24
some words? I'm Professor, sorry, Dr. Sabina Malik. Can I
Professor
share some
Nema,
words?
please share.
Yes,
Professor Nema.
I want to add some words that actually what Dr. Nadia has discussed, she has discussed only the teacher's portion. But then they will give some assignment. It's a total 3-hour session. Okay, just first 1 hour the teacher will be discussed. Okay, that Dr. Nadia showed, and then they will give some assignment to the student in the same class, and they will then give some pictures like this is the subendocardial layer. So if some deposition occurs here, then what kind of problem the patient may suffer? This type of question will be there. Okay, some assignment, the students will group and they will do the assignment. And the final portion will be that some scenario, that means the problem-based questions will be given them, and they will answer the questions accordingly. The probable cause, the mechanism, that means the mode of action, how this happens. That means the total session, it will be divided into 3 portions: teacher's portion, then student assignment portion, then student evaluation portion.
So thank you very much for this clarity and elaboration. So highly appreciated, Dr. Nadia. So now can we move to Professor Rita? Are you there?
Yes, I'm here.
So you were talking about competency from novice to mastery and innovative ways of formative assessment. And then you continue about your focus on writing quality and practical skills. So when you were talking about writing quality, what I understood was that you were telling us that this writing quality feedback was given by the teachers, which was the most important part of the feedback. And they were also given some score. It went to the examination department and the scores were assigned to the students. So do you think that you still call it a formative assessment, or then it acquires the shape of summative?
Yes, actually, it has both the part. One part is the summative assessment, other part is the formative assessment. So actually, we corrected answer sheets and sent to the examination department and for as the internal assessment marks, and that was listed in the examination department. That goes to the summative goes for the summative assessment, and that is for this 30% summative assessment. Later on, those answer sheets were brought from the examination department to the classroom and distributed to the student, so that student can understand that how they have written so that they got these marks. And that's why they evaluate themselves. And if they don't understand that why we are getting out of 5 only 3 or 2, then they used to ask teachers, and there was the brainstorming discussion that you should write this point also, or you should give here figure also, or flow diagram. So all those they are gaining knowledge for writing, that okay, in such a condition we need to add these all things, and for the future they are learning also. And those is the feedback only, and that is the summative part. So the interesting is that one that is the one unit examination, one for going for the summative assessment, and feedback all for improvement, that is continuous, that is the for examination going, that is summative, and the feedback given, that is formative. And in other way, if we say students writing something like giving some piece of question and writing, then they cannot pay that much attention as they are paying during examination, and that is the actual formative assessment that are helping students writing quality. And starting from the novice to the mastery, for the competency that can be do for the skill, that is the practical, as we do the clinical as the BP measurement and the ECG all, so we can do for that. So starting from when students are entering first year student, they don't know how to measure. With the briefing, we are giving knowledge. With the demonstration, we are learning them, and with the brainstorming themselves with the checklist, self-assessment, peer assessment, and repeated measurement, so that they learn and learn and learn competency.
So wonderful. So do you give this feedback on one-to-one basis, or do you give it on the multimedia and all the students are watching and observing while they are discussing about the writing style?
One-to-one student. Because those students who are already okay, I'm okay, ma'am, was, and those are weak and they ask why it is happening, then we used to explain them, and other also used to listen to that. So all are gaining.
And great. And this peer feedback is also one-to-one?
Peer feedback, like suppose in 4 group of student or 5 group of student, one student is assessing, then other 2 student are that is the one student is measuring, one student is subject, one student is measuring, other 2 students are with the checklist, that is assessing. Then observer, and then vice versa, so that each and everyone is learning.
I really appreciate this feedback model. We can practice it and we can make a collaborative, publication from different corners of South Asia, and we can publish it together. So do share your research proposal and study design in detail with all of us. Okay. Thank you very much. Thank you very much for educating us. Thank you everybody for staying with us, and house is open for any questions.
Yes, I just want to share for the integrated learning also. So actually what is happening, I'm very much interested with the coronary artery and other like asthma and all those. In our institute, what is happening that since its inception, like 1994, we have integrated curriculum, and it's not for the 3 subjects, it's for the 6 subjects: anatomy, physiology, biochemistry, microbiology, pathology, and pharmacology. And the curriculum is integrated, and whatever the schedule, that's the course schedule of students, those all are integrated. So always whole course are integrated. So our horizontal integration is very strong, because in first period anatomy, people are anatomy teachers are teaching, then physiology of that is the physiology of that part of anatomy is taught by physiologists, then biochemistry adding, then microbiology, pathology, and at last that's the pharmacology. Before that, the community medicine also. So all are in these 6 subjects are integrated, and this is integrated curriculum from the 1994 for all topics. Yeah. But
so indeed, Professor Rita, by knowing that all these countries, they are involved in integrated curriculum, including Pakistan as well. So what we can do for SAAP is that we can publish a common book of integrative physiology, in which we can write down the we can seek contribution from the people from other disciplines as well in our institutes, and we can write some module based physiology books, and they will be integrated. So anatomists will also be invited to write on the topic like of coronary artery disease, and everybody, starting from anatomy, going to the surgery medicine, horizontal and vertical integration. So we will be serving a very useful purpose for the students, because there are no such books available in the market. So do you guys agree?
Yes, because we have experience from 1994. We had no idea. First, when I exposed to, on this topic in Sri Lanka, when in 2012 SAAP conference, and I was surprised. Oh, because in our institute it was going on, so we had no idea that other places those are not integrated. Then when I attended the same thing in Thailand, then there also it was extensively discussed. Okay, so this and this kind of integration is really very good for the students.
So let's join hands then, and we can plan about the book, right? Dr.
Yes.
Nadia and Dr. Rita and all others are invited.
Thank you so much.
Yeah, thank you. It's a great idea.
Yeah. So, Professor Rashid, some words from you, please.
Thank you, Professor Samina. First of all, I appreciate a lot the organizers, your initiative. It was at the level of SAP. And thanks to Dr. Munaza, she's always the first to arrange such academic activities. Rather, I can say it was a mini conference, not a small activity. And I've been teaching for the last more than 30 years, but I learned at least one new technique from each of the speakers. And the topics were so wonderfully distributed that it was very interesting. It was not possible to move from the screen. Thank you, the organizers and all the speakers.
Thank you so much, sir. And interestingly, Professor Rafiq Dar has already answered the only question that we could have asked him after his very interesting presentation, that how to handle so many students together by giving them exposure to all 4 types of modalities. So he is no more with us in right now. So in his absence, we are grateful to him. Thank you very much, Professor Munaza, for organizing it very well. The chairperson of Education Subcommittee.
Professor Samina and Professor Naima Sultana for joining us. And And then I would also like to request that we should fill the Google forms which Dr. Samina, Professor Samina, which you have shared in various groups, in social SAAP group and in education subcommittee group. If all
Yes,
of us
and
could.
that form is the credit of Professor Munazza, not my credit. I have just circulated and just initiated. So she has made that Google form so that there can be a directory of supervisors in SAP. So everybody is requested to please fill that form so that you can be on board as a supervisor for education or supervisor for physiology research. Thank you so much.
Thank you so much.
Thank you.
Thank you.
Thank you so
Everybody
much.
for staying with us for so long.
Thank you.
Thank you.
Thank you so much, Professor Samina, Professor Munazza, for this excellent session and all the participants. It was truly very, very
Thank
interesting.
you everyone for joining and thank you for teaching us. So today I was a learner and all of you were teachers. So thank you so much once again. Take
Thank you,
care.
Professor
Thank you.
Samina.
Thank you very much,
Thank
everyone.
you so much. Thank you. Let's call it a day.
Thank you, Profession Manager.
Thank you so much. Take care.
Thank
Bye bye.
you.
Allah Hafiz.
Allah.
Thank you.
Allah Hafiz.
Allah
Allah
Hafiz.
Hafiz.